Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
Today's podcast will focus on paroxysmal nocturnal hemoglobinuria, which we'll refer to as PNH moving forward. And I'm honored to be joined today by Dr. David Dingley, Dr. Caroline Piatek, and Dr. Jamil Shamo. Dr. Dingley, if you could take just a moment to introduce yourself.
Thank you, Mona. I'm David Dingley. I'm a professor of medicine at the Mayo Clinic in Rochester. I'm also the director of the bone marrow transplant program. I've had an interest in PNH for approximately 2 decades, and I maintain a substantial practice related to this disease. I'm quite interested in the quality of life related to patients with this disease and how it can be improved, the causes of impaired quality of life, etc. I'm happy to be here with our esteemed team of experts.
Thank you. Dr. Caroline Piatek.
Hi, my name is Caroline Piatek, and it's a pleasure to be here as well. So I'm a non-malignant hematologist associate professor at the University of Southern California in Los Angeles, and I have a research and clinical interest in PNH as well as immune cytopenias. Look forward to this discussion.
Thank you. And Dr. Jamil Shamo.
Hi everyone, I'm Jamil Shamo. I'm professor of medicine and I work at Northwestern University focusing on bone marrow failure. I, like Dr. Dingley and Piatek, have worked in that field of PNH and taking care of patients close to 2 decades now. So it's been actually pretty amazing to see the major development that went on in this field, and I'm so happy to be with you today to discuss further developments. Thank you for having me.
Thank you. And again, thank you all 3 of you for joining us today for this important discussion. So our topic for today's call is a discussion on the management of thrombosis risk in patients with PNH. And sort of a few questions that I had to start the conversation is perhaps we could talk a little bit about which patients do you feel that are at an increased risk for thrombosis in your clinical practice, and how do you sort of identify or risk stratify these patients? And then what do you feel are the most effective strategies for either preventing or managing the risk of thrombosis in PNH, and how effective are those strategies?
So the patients that are at high risk for thrombosis are those with large clone size, usually defined as greater than 50, as well as those that have kind of hand in hand with that is intravascular hemolysis, which is measured by an elevation in the LDH. And then certainly patients' prior medical history of thrombosis and other medical conditions can also contribute to that risk as well. So for patients with classical or hemolytic PNH, the management is complement inhibitor therapy, and there's the data shows that eculizumab as well as ravulizumab are very effective at abrogating the risk of thrombosis in these patients, and in turn improving survival in patients with PNH.
This is very, very important. And as we mentioned before, thrombosis used to be the main cause of death in patients, and probably 40% of patients with PNH will get a thrombotic event, whether in a usual or unusual vascular distribution, mainly venous, but it can be arterial. And I believe it was the group in Leeds years ago who showed that with proper control of intravascular hemolysis with complement inhibition, the life expectancy of these patients goes down to normal, and to a great extent because the incidence of thrombotic events or recurrent thrombotic events goes down to very, very low levels. So clearly identifying these patients and treating them is a critical decision in the life history of these patients.
And I think that the problem sometimes is that when you have a patient who has a certain PNH clone, and they may not necessarily be terribly anemic or hemolyzing, I like the word that you use, something about risk stratification. We don't have risk stratification, with the exception of saying someone who has a larger PNH clone, someone who may have active hemolysis may be at an increased risk, or someone who may have had a thrombotic event previously could also be at an increased risk of a future thrombotic event. But these events are somewhat unpredictable. And I think for that reason, a lot of people prior to the availability of complement inhibitors used to utilize antithrombotics, like anticoagulation, in the hopes of diminishing or decreasing this potential risk, because it's really somewhat unpredictable. So I don't know that we have very good risk stratification tools. And even in patients who are treated, we're all kind of bracing for a potential breakthrough hemolysis, which may actually be associated with thrombotic events. But the data on this association is also lacking. Like, a lot of patients have breakthrough hemolysis, but not all of them develop thrombotic events. And so it's really a very critical issue that I think we need to do a little bit more work. And then also, are there any additional factors that cause somebody or a particular patient to develop thrombosis when many others who have the same disease don't? So I think there's a lot of research that's going on in that regard.
And I guess as a follow-up to that, could you discuss a little bit more about sort of what the role is or isn't currently for anticoagulation therapy, or in addition to the use of complement inhibitors in these patients? Is that something done routinely or not?
So at this point, the patients receiving anticoagulation are those that have thrombosis. So in the past, there was when not everyone had access to complement inhibitor therapy, you may have them on prophylactic doses of anticoagulation. But at this point, given the very effective or the effectiveness of complement inhibition to decrease that thrombotic risk, there's not really a role for prophylaxis or primary prophylaxis in this setting. And then the presence of thrombosis is also an urgent indication to start a patient on therapy. And I would be interested to hear from the group if a patient presenting with thrombosis, if that affects your initial choice of a complement inhibitor therapy. Would you treat them with C5, or would you be open to using other agents?
So Caroline, to understand your question, you wondered if someone presents with a thrombotic event, what would the choice be?
Right, of your complement inhibitor.
So I think that's actually, it's a very good question, because what do you do with someone who, we're presuming that this is like an episode of significant intravascular hemolysis that's complicated by thrombosis. And I actually have given this like plenty of thoughts, because ideally you'd like to utilize something that would completely suppress intravascular hemolysis, and very quickly. So if you looked at the steady state of essentially how long it would take a complement inhibitor to achieve a steady state whereby it's probably likely to exert its therapeutic effect, in the case of ravulizumab, for example, it's instantaneous. The minute you give the drug, it has sufficient quantity in the blood. In the case of pegcetacoplan, for example, it takes 4 weeks, which was the reason for why people had a 4-week period of running with eculizumab to get to a particular steady state of this agent. So I don't know that I would be utilizing pegcetacoplan in the setting of active thrombosis, but I'm curious to hear what others think. And then by the same token, for iptacopan, a proximal complement inhibitor, factor B inhibitor, we're talking about a steady state of about 5 days. And so again, that's in the absence of a completely comparative data, I think it's reasonable to consider C5 blockers, either in the form of eculizumab or ravulizumab, for someone who has active hemolytic episode combined with thrombotic event.
And I guess I have one follow-up question to all three of you, sort of based on listening to all of your insights. What do you think the role of patient education and sort of shared decision-making is in these situations where you have patients that, might have previous thromboses or their first, and sort of what are those discussions that you will have with patients when deciding how to move forward, and how important is sort of the patient understanding and education component of this process?
I would say that educating the patients, not just to the side effects of the agents that they're going to be utilizing, but also to recognize certain adverse events, right? So we're all worried about infectious complications with the complements. So they need to become aware of what to monitor for and when to seek medical attention. By the same token, emergence of certain thrombotic events would also need to be discussed, because we all know even if someone is on anticoagulation, while it might significantly reduce the risk of a future event, it doesn't completely abrogate it, right? So I couldn't overemphasize educating the patients on what to monitor for and when to seek medical attention.
Yeah, so I agree. And the patient needs to be aware of the importance of compliance. They need to be very aware of what can trigger a breakthrough hemolytic event. And they need to really understand the disease and why we're treating the way we're treating. And most people are able to understand this quite well. And for any chronic disease, in my view, the more the patient understands, the lighter the burden becomes. Because the easiest part is to prescribe something. The patient is going to be the one who's going to be carrying the burden of the disease and this therapy. And the more they understand about the illness, I think the lighter the burden becomes, and the more aware of what can happen they become.
Right, excellent. Well, I think we're at a great place. Thank you again, all three of you, for taking the time to have this important discussion with us today.